1-year online program designed to equip you with advanced knowledge and skills in managing critically ill children. Our aim is to provide you with high-quality educational materials and up-to-date pediatric critical care information delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is current, evidence-based, and well-structured. This comprehensive fellowship is structured as 3 modules, 16 weeks each, with a total of 96 credit hours of in-depth training, delivered by a world-class faculty of international experts. Our curriculum ensures that you stay at the cutting edge of pediatric critical care. Your journey with us includes weekly lectures, MCQs, interactive case-based discussions, journal clubs, and virtual simulations, featuring the latest evidence-based pediatric critical care knowledge, plus a dedicated mentorship program to guide your learning every step of the way. From mastering mechanical ventilation and sepsis management to specialized training in mechanical circulatory support and neurological critical care, you will develop essential skills to manage critically ill children in any healthcare setting. Upon completion of the fellowship, you will enhance your credentials, advance your career, and improve your patient's outcome. With access to a cutting-edge smart learning platform, virtual case scenarios, and real-world applications, this fellowship bridges the gap between knowledge and clinical practice. Join a growing community of critical care professionals who have transformed their careers with this fellowship. Don't miss this opportunity.
Hello, everyone, and welcome to our Pediatric Critical Care Fellowship webinar. Today, we have a very special webinar, and because tomorrow we are starting our fellowship, we want to give you the final highlights about our fellowship program, and also our topic that we have chosen today to discuss is very, very important to our critically ill children, because it's not only important to be precise and accurate in selecting and choosing the therapeutic option, but it's also very important to monitor the response to these interventions. So without monitoring, without having metrics and objective to follow the response of our patient to this intervention, probably we are not going to benefit the patient, and we might induce harm than induce benefit. Today, we have great panelists, moderators, and speakers. Dr. Asma Salo from South Africa, Dr. Anna Gunz from Western University, Canada, Dr. Bassam Al-Bassam from King Faisal Hospital, Saudi Arabia, Dr. Lumbini Zuzu from South Africa, and Dr. Bij Bergres from Western University, Canada. And also we have Brianna Maklev, who is going to talk about monitoring critically ill children in high resource settings. Dr. Bassam is going to give samples of the fellowship materials. Dr. Lumbini is going to talk about how to monitor our critically ill children in low resource settings. Dr. Asma Salo is going to moderate her discussion. Dr. Bij and Dr. Anna Gans are going to moderate the discussion of Dr. Brianna talk. So very rich, very good diversity from all over the world. And without further ado, I'm going to let Dr. Bassam Al-Bassam to give you some instructions and some information and samples about our fellowship. Please, we are starting our fellowship tomorrow if you haven't joined yet. If you want to join, please use this promo code webinar10 to get 10% discount. Code expires tomorrow. And the floor is yours, Dr. Bassam.
Thank you, Dr. Amr. It's a pleasure to be here. I'm excited to talk about the fellowship. So do you guys see my screen?
Yes, sir.
Okay, awesome. So my name is Dr. Bassam Al-Bassam. I'm a pediatric intensivist from King Faisal Specialist Hospital and Research Center in Riyadh. So let's just jump in. And my son is here. He's my co-presenter. So for our online fellowship, it's a 1 year online fellowship, and it's going to have 3 modules. And each one of these modules is going to span 16 weeks, okay? And in every week, you're going to have a lecture, a journal club, you'll have a lot of multiple choice questions, and you'll also have clinical case scenarios relevant to the topic. So it's going to be intense, it's going to be a lot of work, but hopefully you guys are going to learn a lot in every single one of those weeks. And then once you're done with the program, you're expected to graduate to a trainer level. So you'll be able to join the tutoring panel in incoming programs. You're going to gain expert level knowledge in pediatric ICU. And of course, that's invaluable. And then finally, you also get a certificate from the American Association of Continuing Medical Education. So for the board, as you can see, with the panel today, it's a diverse board. We're coming from everywhere in the world. We have people from the US, Canada, the UK, South Africa, Saudi Arabia, and Egypt. So hopefully from that diversity, you're going to gain a lot of different experiences, a lot of knowledge. An important thing about the material itself, it's going to be very interactive. You're going to see questions and answers. The evaluation and assessment are going to be based on those, and we're going to focus on critical thinking. We're not going to focus on rote memorization. We want you guys to understand the concepts and build on that. Again, diving a little deeper into every week. So at
Voice, I think we'll go with the second presentation till we fix the problem. So Dr. Bariana is going to start her talk about monitoring in high resource settings. And I'm going to let Dr. Paige Burgess to introduce her, or Dr. Anna Gons, because both of them are going to moderate the session.
Hi, everyone. It's with great honor that I introduce Dr. Brianna McKelvey. She is a pediatric intensive care doctor as well as program director at the Children's Hospital of Eastern Ontario. She's assistant professor at the University of Ottawa in Canada. She has an MSc in significant expertise in quality improvement and patient safety that was granted from the University of Toronto in Canada. Her interest in quality improvement stems from a belief that all children should have access to the best and safest healthcare, and was with great pleasure that I hand over the floor to Dr. McKelvey.
Thanks so much, Anna. Okay, I usually use Teams, so I'm gonna try and share my screen. Can you guys let me know when you can see it? Are you able to see that?
Not yet, but I can share the screen from my side and show your presentation if you want.
Okay, sounds good.
Okay.
So I was tasked today with talking about patient assessment and monitoring in the PICU. And I thought it would be good to start with just a quick overview of why we want to monitor our patients in the ICU and what kind of parameters are important to follow. And for so many of our PICU patients, what we're trying to do is either anticipate or treat shock. And so if we remember, shock is defined as an imbalance between oxygen consumption and oxygen demand, leading to inadequate tissue perfusion. We can go to the next slide. So when we talk about an imbalance between oxygen consumption and oxygen delivery, the oxygen delivery equation is cardiac output times arterial oxygen content. So how much blood we're pumping around times how much oxygen is in that blood. And then our cardiac output is further broken down into heart rate times stroke volume, and stroke volume is broken down into preload, contractility, and afterload. And so if we look at all those variables, these are all the variables that we manage within the ICU to try and optimize oxygen delivery and treat our patients in shock. And derangements in any of these variables can put our patients at risk of shock. So if we think of, from a heart rate perspective, patients that are overly bradycardic or in tachyarrhythmias with inadequate diastolic filling time, disorders of preload would include patients who are hypovolemic or patients who are vasoplegic and have reduced venous return. Disorders of contractility, we can see in patients with myocardial dysfunction. Afterload, so a patient in a hypertensive emergency. And then obviously for hemoglobin, it's bleeding, and for oxygen saturation, it's hypoxia. And a decrease in any of those variables will lead to compensatory changes in the other variables until a critical point where oxygen delivery has dropped so much that it's inadequate to meet the body's needs for aerobic respiration, and then we move into anaerobic metabolism. And so when we talk about oxygen, why is it so important? It's so important for energy production. So if we think back to medical school, back to the other slide. The way that we derive energy. So glucose is broken down through glycolysis to pyruvate. And then if pyruvate has oxygen, it can move into the Krebs cycle, participate in oxidative phosphorylation, and generate 36 ATP. So much more energy efficient than if we don't have oxygen, then we move into anaerobic metabolism where pyruvate is converted to lactate and only generates 2 ATP. And why do we need ATP? We need ATP for any of our cellular processes that rely on active transport. So the sodium potassium exchange pump, muscle contraction, DNA replication, synthesis of protein molecules. And so if we don't have enough ATP, all of those processes are going to fall apart and contribute to cell death. So it's just a good reminder of kind of the basic principles of why we care so much about oxygen delivery. And patients who are in shock, it can be either because they have increased consumption, so increased VO2 from, seizures, fever, or a decrease in their DO2 like we were talking about with the oxygen delivery equation. I'm just going to close my door because it's making a bit of ambient noise. And when we're talking about shock and oxygen delivery, it leads us to an important concept in monitoring our patients, which is their mixed venous saturation. So we can only monitor this in patients who have an IJ central line. But I think the concept is important, which is that if we assume that oxygen leaving on the arterial side is 95 to 100% saturated, when it gets to the capillary beds, it offloads O2, picks up CO2, and heads back to the right atrium. And the saturation in the right atrium, or actually true mixed venous is in the pulmonary artery, reflects how much oxygen the tissues have had to use. And so a normal mixed venous would be somewhere between 70 to 80, and the normal difference between the arterial and the venous side should be about 20 to 30. And so before we start to see the lactate going up, one of the first indicators of shock can be a change in our mixed venous. And so if the mixed venous is lower than expected, what it reflects is that the tissue beds have had to use up more oxygen as it's passed through than it usually would because of a combination of drop in DO2 or increase in VO2. Oh, sorry, back to the warm and cold shock. Also, when we're talking about assessing shock at the bedside. We typically subdivide shock into warm versus cold shock, which is a bit simplistic, but can apply hopefully to most of our patients and doesn't require, invasive monitoring to get a sense of what the underlying pathophysiology is, which could guide our management. So patients in cool shock, those patients tend to reflect that they've probably got issues with myocardial contractility and an increase in their afterload, so an increase in their SVR, which leads them on exam to be cooler. And these patients have, poor pulses, prolonged cap refill. They've got a narrow pulse pressure, which is the difference between the systolic and diastolic pressure and reflects how hard or easy it is for the left ventricle to eject. And so a narrow pulse pressure reflects a lower stroke volume versus a wider pulse pressure. In Warren shock, patients are vasoplegic, so they're diffusely vasodilated, and it's actually really easy for the heart to pump. And so they've got a wide pulse pressure, a low diastolic, bounding pulses, flash cap refill, and their issue is more with even though they have a good cardiac output, it's inadequate to meet the demands of the tissues because all the arterioles are diffusely vasodilated and we've lost the ability to autoregulate. And so in those patients, they have, preserved myocardial contractility, but a low SVR, and our therapies are going to target increasing their SVR. Of course, not all patients fit neatly into these two categories, but from a fairly simple bedside exam, you can glean a lot of information about what might be going on with your patient and how best to manage them. We can go to the next one. Also, from a shock perspective, when we're trying to determine to what degree our patients are affected, we can look at their end organ function. So again, if oxygen delivery is inadequate and our tissues are not adequately perfused, we're going to start seeing derangements in their function. And so from a CNS perspective, patients can be, confused, comatose, have seizures. From a respiratory perspective, we can see ARDS. From a liver perspective, a transaminitis and alterations in liver function. We can see acute kidney injury with elevated BUN, creatinine, and electrolyte abnormalities. We can see changes in hematologic function with an increased INR, decreased fibrinogen, thrombocytopenia. And these are all things that we can look for in our lab work and on exam to get a sense of if our patients are in unresuscitated shock or not. So this was just kind of a quick background of what we might be looking for as we are monitoring our patients in the ICU and what we're trying to anticipate and aim our therapeutics at. The next thing I wanted to talk about was assessment and then monitoring. So I made this presentation a bit too long, so I'll try and run through it quickly. I think probably most people on the call are familiar with the primary survey, but I just wanted to reiterate, this is the most important component of patient assessment. And anytime I go to see a patient, I'm quickly running through in my head where they're at in terms of their ABCDEs. And these are in order of, degree of life-threateningness if they're deranged. So when we talk about airway, people usually say, is it patent and protected? But what does that really mean? So when you go to assess a patient, are they breathing on their own? And if they're breathing on their own, are they moving air between their mouth and their lungs? And if they're not, why not? So on the next slide. So if they're not, it's important to differentiate between Sturdor versus Stridor. So Sturdor, we see more in patients with a decreased level of consciousness and compromised airway tone, who can have more of that snoring sound and are going to respond to a jaw thrust. So this would, be in the severe TBI patient who comes in and you're finding that that they are not protecting their airway, or the patient with status epilepticus. And then if you're hearing more of an inspiratory stridor, that reflects more an anatomical narrowing at the level either above, at, or below the vocal cords for a multitude of reasons, croup, trauma, etc., and that won't respond as well to a jaw thrust. And then on your airway assessment, if you're going to have to escalate to an advanced airway and intubate, it's good to take a look at trying to anticipate if it will be a difficult airway. About 50% of pediatric difficult airways are unanticipated, but we try and anticipate them as best as we can to prepare to manage them. So you want to look to see if the patient is dysmorphic, has any evidence of, an underlying syndrome that could predispose to a difficult airway, like Pierre Robin with micrognathia and a retrograde chin. We also want to look at if there's any, trauma or evidence that there could be something obstructing the airway. It can be difficult to assess the Mallampati in kids at the bedside. We want to look also for neck mobility. So patients who are in a C-spine collar, patients who have any limitations in their neck mobility, and all of these could contribute to difficulties in managing the airway. After our airway assessment, we want to do the breathing assessment. So we look at the respiratory rate and the oxygen saturations from a vital sign perspective. Then we want to look at accessory muscle use. Are they working hard to breathe? And then take a listen for clues as to why they might be working hard to breathe. Do they have good air entry? Do they have crackles? Do they have wheezes? Is this fitting more with an obstructive versus a restrictive pattern? And then once we manage the B, we move on to the C. And so from a circulation perspective, we want to look at their heart rate, their blood pressure, and their pulse pressure from a vital sign perspective. And then we want to feel their pulses, check their capillary refill time. And then this is typically also where I check the liver edge to see if there's any signs of compromised myocardial function. Once we've addressed the circulation, we move on to disability. So we want to look at their pupillary response to light. We want to assess their GCS, and I encourage people actually to take out their cards when they assess their GCS. I notice, when we have trauma patients come in that there can be a lot of variability in the assessment of GCS, and it matters a lot in terms of both management and prognostication. So very important to do that part well. We want to look to see if there's any lateralizing signs, so any signs of stroke, and then any evidence of seizures, tachycardia, tonic posturing, eye deviation. And then D is where I usually remind myself to check the glucose because it can be something that gets forgotten during the primary survey. And then E is exposure, so measuring their temperature and looking at their skin and extremities for any clues as to what's going on. So, I know we're speaking to people who are coming from differently resourced areas, and I just wanted to emphasize the importance of the ABCDE patient assessment because you can glean so much information and it doesn't require any kind of invasive technology and gives you a really good sense of what's going on with your patient and is kind of one of the first principles of ICU care. And then when I'm going to see a patient, I'm always, if I'm worried about shock or if they're in shock, then I'm always putting all of that together to get a sense of their end organ perfusion. So their vital signs, their lab work, when I put this together, am I happy with their end organ perfusion or am I worried about it? Are they oliguric? Do they have deranged vitals? Is their lactate high, or are all those things reassuring? So we can go on to monitoring next. Amr, how much more time do I have?
You have 20 minutes.
Oh, okay. Well, then we're okay. So from a monitoring perspective, ESPNIC put out some recommendations back in 2020 about monitoring in PICU children. So if anybody's interested in reading more about it, I didn't put in anything about, assessing heart rate, O2 sat. Those are fairly straightforward. I wanted to talk more about invasive blood pressure monitoring, CVP, etc. So our goals of monitoring are that we want it to be accurate, precise, valid, stable, reliable. And in terms of hemodynamic monitoring, we want to make sure we're happy with tissue perfusion. And if we're not, we want to get a sense of why and what the underlying pathophysiologic mechanisms are so we can target our therapeutics. So these are all the different parameters we can monitor. When we talk about blood pressure, we're talking about the systolic, which is determined by the force and volume of blood ejected from the LV into the aorta, and the diastolic, which is the lowest blood pressure within the arterial system and is determined by the resistance in the arterial tree, or the SVR. We also talked a bit about pulse pressure, which is just the difference between systolic and diastolic and reflects the stroke volume. And again, if it's narrow, it's concerning for an issue with, myocardial contractility. And if it's wide, it reflects more an issue with lower SVR. So non-invasive blood pressure cuff monitoring, we typically do with automatic cuffs. And it's important to understand the limitations of automatic cuffs and why we might use invasive blood pressure monitoring. So if we think of what a cuff does, it squeezes until the pressure is higher than the systolic and it occludes the arterial pulse, and then it gradually reduces the pressure until it senses a pulse. And then it continues to reduce until it doesn't sense a pulse, and that's the diastolic cutoff. And the way the automatic cuffs work is as the pressure is reduced, it creates oscillations against the arterial tree, which are sensed by the cuff. And the map is is where the amplitude of the oscillations is highest. So sorry, if we go back to the other slide. It's the middle part in that waveform. And so the automatic cuffs are measuring a map, and then they use a computer algorithm to generate a systolic and a diastolic. So you can usually rely on the map for a non-invasive cuff. However, the systolics and diastolics, especially at the extremes of blood pressure, so very low and very high, can be less reliable. And so in patients who are more unstable and we want a more accurate real-time continuous blood pressure monitoring, then we consider an arterial line for invasive monitoring. So this is indicated in patients who have uncorrected hemodynamic instability. Like if you have a patient in shock, but you've given some fluids, started them on a bit of low-dose epi and they've settled, we wouldn't necessarily put an ART line in that patient. But if we're having difficulty and we're titrating those inotropes and vasoactives, then we would put in an ART line. If you need really frequent blood sampling, so a patient in DI who you're doing a sodium every hour or something, and then rarely an inability to apply a non-invasive cuff, so a patient who has extensive burns or skin condition that we can't put a cuff. We need to know the complications of an ART line before we insert. Complication rate's about 15%, but serious complications are less than 5%. And, we can think about thrombosis, embolization of air or clots, infection, bleeding, obviously at the time of insertion, but actually the bigger risk of bleeding is if there's any issues with the tubing connection and it gets undone, a patient can bleed out very rapidly if it's not noticed. Retroperitoneal bleeding, if it's a femoral artery, because the retroperitoneal site is not compressible. Hematoma, and then especially in patients who have hemodynamic instability, you can see vasospasm during the insertion attempts. In terms of sites that we do, the radial artery is the most common and the most popular. Brachial artery is not recommended given there's no collateral circulation there. And axillary artery we don't do as often because it's more technically difficult. The posterior tib and dorsalis pedis would be my sites that I would do if I was unsuccessful at the radial artery. And then in patients who are more hemodynamically unstable, where we're having a lot of trouble getting an ART line, then we'll do a femoral arterial ART line, but the risks are higher than with the peripheral ART lines. So once you've successfully inserted the ART line, the next step is to transduce it. And how does that work? The transducer converts pressure from the artery via the fluid-filled tubing in the connector into electrical energy and gives you that pressure waveform. This is just an example of what the equipment looks like. And then this is the waveform. So we can see the upswing is systole with ejection, and then the peak arterial pressure is the peak systolic pressure. And then we start to see systole slowing down, and the anacrotic notch, or sorry, the dicrotic notch is where the aortic valve closes and bulges into the aorta, causing a brief increase in pressure. And then there's the diastolic runoff. Distal pulse amplification, just kind of important to know to understand why the waveforms might be different depending where the arterial line is the idea that as the pulse wave travels further from the heart, so further from the central arteries to the peripheral arteries, you'll actually see there's reverberations of pressure that reflect back and increase the systolic peak pressure and increase the difference between the systolic and the diastolic. However, the means will be the same. So this is just, an indication of the different morphologies you can expect depending where the art line is placed. The issue with art lines is they are a lot more accurate than the non-invasive, but they're more subject to mechanical complications. And so it's a really common issue we have in the ICU where the art line and the non-invasive are not correlating, and we're trying to determine which one's more accurate. And so it's important to understand the concepts of over dampening and under dampening with art lines. So over dampening is when the arterial pressure that's being read by the monitor is lower than the actual arterial pressure. And that can happen when there's something obstructing blood flow, like if there's a kink or if there's a clot, and is reflected by the waveform being lower amplitude. Under dampening, oh, sorry, if we can go back. Under dampening is the opposite, where the blood pressure is on the monitor overestimates the true blood pressure. And we can see that more in patients who have turbulent blood flow, and so the catheter is moving around. And so when we're trying to get a sense at the bedside, I would say our most common pitfall is that the art line will read changes in blood pressure earlier than the non-invasive, and we assume that it's an art line problem, but actually the patient is hypotensive and we need to be intervening. But sometimes there are actual problems with the art line. So a couple of things we can do to assess. We can do the square waveform test. And so the nurse can deliver a rapid flush, and then you'll see that there's a square wave. And then once it starts to read, there's some oscillations before the arterial waveform comes. And optimally dampened art line, you want to see 1 to 2 oscillations. If there's fewer than that, then it's over dampened. And if there's more than that, it's under dampened. The other thing sometimes I'll do is I'll do a manual cuff pressure with a Doppler to get a sense of which one is approximating the true blood pressure. So with the art line, we can look at the waveform to get a sense of the patient's underlying hemodynamics. So a short systolic time versus a longer systolic time, and then marked respiratory swing, also known as pulsus paradoxus. So pulsus paradoxus is when there's a difference of more than 10 millimeters of mercury in the systolic blood pressure between inspiration and expiration. And it's reflective of either increases in intrathoracic pressure or a need for fluid. And sorry, we can go to the next one. So here's an example of pulsus paradoxus. And what happens is that on inspiration, there's an increase in the negative intrathoracic pressure, drawing more blood into the right heart, which reduces the amount in the left heart and reduces the systolic blood flow. So if the preload is low, that difference is exaggerated and reflects that a patient could benefit from fluid. However, you also have to take into account if there's any other derangements in intrathoracic pressure that could be causing pulsus paradoxus and not volume status. So patients with cardiac tamponade, patients with asthma, patients with attention pneumothorax, increased intra-abdominal pressure, all of these can lead to pulsus paradoxus as well. We can go to the next one. And then just a review of what we're talking about with volume responsiveness. So again, back to medical school, this is the Frank Starling curve and is just an example of why increasing the preload leads to an increase in stroke volume in a normal heart. And so what happens with an increase in preload is that it pulls the actin and myosin cardiac muscle fibers further apart and increases the resting tension within the LV. And what that means is that during relaxation, it snaps back further and is able to generate more of a contractile force, which increases the stroke volume. However, this is only true in a healthy heart. In a failing heart that's had progressive volume overload, those actin and myosin fibers are stretched so far apart that they can't snap back in the same way, and actually volume can be harmful in those patients. We can skip this part because I know we're running low on time. Can skip that too. These are just, we don't measure this at CHEO, so I've never used it, but it's measuring the variability to produce a real-time number about how fluid responsive you think the patient will be. Sorry, the last slide was just about zeroing the ART line. So just a reminder that if your arterial blood pressure is not reading what you would expect, make sure that it's been zeroed at the right site. So it should be zeroed at the height of the right atrium. And you want to open the stopcock to air and close to the patient until there's a flat line and then back to the patient. And these are just some of the recommendations from the SNCC guidelines, but again, can review those separately if you're interested. So next I wanted to talk about CVP, so central venous pressure, which we can monitor with any central line that we can get to sit at the SVC and RA junction. So indications, so our post-op cardiac patients come back with these lines. And then patients with hemodynamic instability, but again, the ones that are more difficult to manage, you're titrating inotropes, those are the patients. If they settle with just some basic, treatment measures, we don't necessarily put central lines in those patients, especially if they're not intubated. Complications at insertion depend on where it's inserted. So there's the risk of arterial puncture, which is lower now with ultrasound guided. If it's a subclavian or an IJ, there's a risk of a pneumo or a hemothorax. If it's a femoral line, there's a risk of retroperitoneal bleed. And if the line is too deep, it can put patient at risk of dysrhythmias. And then there's the complications of the indwelling line, which include thrombus, embolization, and infection. The sites that we insert, so IJ and femoral line would be the most common in our unit. There's also subclavian, and then nowadays we insert PICCs, usually in the brachiocephalic vein, but also can be done in the saphenous vein. So when measuring the CVP, the trend is much more important than the absolute number because there's a lot of factors that influence the CVP. So the patient's fluid status, the intrathoracic pressure. So a normal CVP in a spontaneously breathing patient is measured when we've got negative intrathoracic pressure breathing versus if a patient's intubated and we now have positive pressure, that's going to increase the baseline CVP. RV mechanics. So a patient who has a tricuspid valve issue with regurg, that's going to increase the CVP. If they've got RV dysfunction, that's going to increase the CVP, or pulmonary hypertension. So all of those can lead to increases in the CVP. Oh, sorry, can we go back a slide? Arrhythmias, and then, sorry, like I said, the trend is more important than the absolute value. And then this is just a pictographic to remind us of the pressure gradient that determines flow between our vena cava to our RA typically is dependent on the negative intrathoracic pressure generated during inspiration, creating that pressure gradient. And so we can, reduce the venous return by intubating patients because now they have a positive intrathoracic pressure. We already spoke about the Starling curve, but the lower red line is just an example of what happens in a failing heart. And in those patients, again, they get volume overloaded and those muscle fibers get stretched and they can't bounce back as well. And so those patients can get worse if you give them fluid. However, sometimes they come in, they haven't fed as well, and they are actually dry. So it's always worth a test bolus in those patients to see whether they're fluid responsive or not and where they are on that curve. And this is just a pictographic example of the actin-myosin and resting tension. So just a review of the normal expected pressures within the cardiac chambers. So the right atrium is typically 0 to 8. The right ventricle is obviously age dependent, but should be about a 5th systolic. The LA pressures are usually slightly higher than the RA pressures, usually more like 5 to 10. And then the LV pressure, again, is going to be the expected systolic blood pressures based on age. And this is just that lovely CVP waveform that we all learned in medical school again, but is represents the different aspects of atrial systole and diastole. So the A wave is at the end of diastole when we get the atrial ejection into the RV, and that increases the pressure within the right atrium. Then the atrium relaxes and we get the pressure reducing, the X descent. And then the V wave is when the atrium is starting to tense up, but the tricuspid valve is closed, so it increases the pressure again. And then there's diastole, and then the atrium entering, atrial diastole, and then ventricular diastole. Just some examples of some problems that can occur that we can see in the CVP waveform. Do you mind yeah, there we go. So if the A wave is larger, it represents increased resistance in the RV. So, our post-op tetralogy of Fallot patients who have RV diastolic dysfunction or pulmonary hypertension patients can really rely on that atrial contraction at the end of diastole for ventricular filling. And then CAN and A waves, we see when there's AV dissociation. And so the atrium is contracting potentially when the tricuspid valve is closed. You can keep going. So the other utility of a central line, other than measuring the CVP, is to give us a mixed venous. Now, remember, a true mixed venous comes from the pulmonary artery, but we can measure a pretty accurate mixed venous from a central line if it's positioned at the SVC to RA junction. And we want that mixed venous to be reflective of the IVC and the SVC sat. And again, if the mixed venous is low, this either means there's increased oxygen consumption and/or increased oxygen delivery. If the mixed venous is high, it can be that we have decreased consumption. So we can see this in patients under GA, or unfortunately in patients who are brain dead, or increased oxygen delivery like in patients who are on inotropes. Just a pitfall when it comes to looking at the mixed venous is to make sure the line's in the right place, because if it's in the SVC and you're measuring an SVCO2, it could be either an over or underestimation of the mixed venous. So like in a baby where their head is proportionally larger, their SVCO2 is going to be lower than their mixed venous. And again, just a summary of the ESPNIC recommendations around CVP. Something else we monitor within PICU is the end tidal CO2. And so this is what the waveform looks like. Obviously on inspiration, the level of end tidal CO2 measured will be 0. Then there's the expiratory upstroke that reflects the CO2 out of the large upper airways. And then there's the alveolar plateau. And the end tidal's measured at the end of the alveolar plateau before the inspiratory downstroke. And what the end tidal CO2 can tell us is obviously what the patient's CO2 is in real time versus having to do continuous cap gases, but then also can give us a sense of some underlying derangements. So when there's a slower upstroke, like in the second pictograph, that can be reflective of obstructive lung disease where the lungs have a harder time emptying. If it's increasing, we worry about hypoventilation. If it's decreasing, there's hyperventilation, or it could be a perfusion issue. So if you have a large pulmonary embolus, the amount of CO2 being dropped off and picked up to be breathed out is going to be lower, even though the body's CO2 is higher. The Curare cleft is where you see that patients are starting to try to initiate spontaneous breaths, but maybe they're too weak, maybe they're coming out of muscle relaxation and aren't able to do it. And then the other thing we use end tidal for is guiding our resuscitation. So in patients who have in-hospital cardiac arrest, during CPR, we watch and monitor the end tidal to make sure that we are getting perfusion. Measuring cardiac output at the bedside can be a challenge. Again, we talked about mixed venous and lactate. Lactate is a good indicator of end organ perfusion because, again, if we have inadequate oxygen delivery, we'll start to see a switch to anaerobic respiration. And we know that a failure to normalize lactate levels within the first 12 to 24 hours in ICU is associated with more adverse outcomes. So it's certainly an important thing to monitor, but is kind of a crude indicator of cardiac output. Also remember that there's other reasons for patients to have high lactate. So if they have a type 2 from, liver failure or something else, it might not be reflective of shock or a problem with end organ perfusion. Transpulmonary dilution, again, we don't tend to use that in our center because it has to be used in patients who have a PA catheter. And the recommendations are against putting in PA catheters just given the risk of complications versus the benefits of the enhanced monitoring, unless it's certain post-op cardiac patients. But the idea with transpulmonary dilution is we use thermodilution by injecting cold saline. And if the cardiac output is good, the saline is going to travel more quickly and lose less temperature, versus if the cardiac output is lower, it's going to be slower and the temperature gradient is going to be higher. We can go to the next one. And it generates a curve, and the area under the curve is inversely proportional to the cardiac output. Another way we can assess cardiac output at the bedside is through echo, which can give us a sense of biventricular function, of any cardiac anatomical issues, fluid responsiveness, pulmonary hypertension, and it is strongly recommended in patients who are hemodynamically unstable. However, it only gives you a point in time, so it can be helpful to do serial assessments. And I know that there's a lot of intensivists now who are comfortable with bedside echo, but it's helpful to have different moments in time to get a sense of where your patient is going. And then to just quickly touch on PA catheters, I don't know how many people on the call use them. They can be really helpful. They can give us a lot of information, but again, they're technically challenging and higher risk of complications, and so are not routinely recommended in hemodynamically unstable patients. They're more in certain post-op cardiacs, like patients with pulmonary hypertension. But it has the ability to give us a true mixed venous. We can measure the PA pressure, so again, can be a concern in patients with pulmonary hypertension. We can measure the RV pressure during placement. And then if you do a wedge pressure to occlude the pulmonary arterial forward flow, you can get a sense of the LA pressure. So in patients who have myocardial dysfunction and develop LA hypertension, you'll see a higher wedge pressure. And then we can also derive variables from the PA catheter for SVR and PVR. Sorry, we can run through this because I know we're getting close to time. We can go to the neuromonitoring section. So neuromonitoring, so these are an example of NIRS. We can go to the next slide. And so uses characteristics of oxy and deoxyhemoglobin to generate an estimate of the venous saturation within the head, again, giving us kind of a sense of the SVCO2 and how well perfused the brain is. We don't have any evidence towards what should be the normal values in pediatrics and how this should influence management, but we do tend to use it as kind of a surrogate marker, and it can be helpful if you see like a drop and it's associated with other changes in the patient's status, or if there's a large differential, you're worried about stroke. And then some units use renal NIRS, again, as a marker of end organ perfusion in patients with shock. ICP monitoring. So in our severe TBI patients who have an ICP probe, whether it's an EVD or an interparenchymal probe, we can measure the ICP. This is just examples of different waveforms. So P1 is based on the systolic blood pressure. P2 is an indicator of the cerebral compliance, and then P3 is the closure of the aortic valve. And so what you'll see in patients who have poor compliance is that there's a spike in P2 and it becomes higher than P1. And then in patients with really elevated ICP, you'll actually see that P1 and P2 fuse. So we can get a sense from the morphology of the waveform, but also from the absolute number, because, based on the TBI guidelines, we treat patients who have an ICP greater than 20. Transcranial Doppler, we're not currently using this in our unit, and I know that there is so far no evidence for it in pediatrics, but it's been widely adopted in adult units, and I know quite a few peds neurocritical care units are using it, and it essentially assesses the velocity of flow in the middle cerebral artery to get a sense of whether there is increased ICP and either enhanced or reduced blood flow to the brain depending on the ICP. Other neuromonitoring that we can use, so continuous EEG is being more widely adopted and really depends on, you know, kind of the resources within your institution. Amplitude integrated EEG, so similar to BrainsZ within the NICU, can be interpreted by the intensivist or the nurses at the bedside and give a sense of whether the patient's seizing or not. Pupillometry measures the response to light and can be indicative of ICP. Jugular venous bulb oximetry, again, looking at the mixed venous and oxygen consumption within the brain, and then cerebral microdialysis. There's not a lot of evidence for the last three, really just for continuous EEG, but I know different institutions use it differently depending on their practices. And then just a quick statement that all of these are assessing the macro circulation. We're not able to assess what's actually happening at the capillary bed. So even if you optimize the hemodynamics, sometimes you'll see that patients still have an increase in their lactate and compromised endocrine perfusion. And we assume that's because there's now issues with the Krebs cycle and oxidative phosphorylation that can occur from endotoxins produced by bacteria or cytokines or toxins such as cyanide, that we really don't have a great way currently of either monitoring or targeting our therapeutics. So I think that might be kind of the next frontier. Okay, so that's a super quick overview of patient assessment and monitoring in the PICU.
Thank you so much, Dr. McKelvey, for that fantastic presentation. I would just like to take a moment to invite anyone to insert any questions that they have or points of discussion for Dr. McKelvey in the Q&A box. I know we have some feedback here. Amazing presentation. So thank you very much.
Oh, sorry, it was so fast.
No, I think it was
walk through it quickly.
One thing that I was hopeful that maybe if you would indulge us in drawing on some of your expertise in quality improvement, especially in thinking about some of our more invasive monitoring techniques, specifically central lines. You mentioned some PA catheters, arterial lines, and the risk associated with those invasive monitoring techniques, particularly around infection. What are some of, some pearls that you can provide to the audience today that you've experienced from a QI lens to try to minimize those complications?
Yeah, great question, Paige. So we're part of an organization called Solutions for Patient Safety, which is an international organization out of the US that basically, because they have so many member hospitals, they've been able to generate evidence around what elements within a infection prevention bundle are the best bang for your buck for actually preventing infection. And those SPS bundles are widely available without even joining the organization. So we've implemented the CLABSI bundle, which helps to prevent central line associated bloodstream infections. There's also the CAUTI bundle to prevent UTIs. And it's elements such as, having an insertion checklist, which includes making sure the patient is fully draped and making sure you're using, the right sterilizing technique for inserting the line. There's a lot about maintenance for the nurses at the bedside with tubing and how they access the lines, but it's helpful because you don't have to waste time implementing changes that aren't actually going to reduce infection, because as we probably all know, even implementing the smallest change is a ton of work, especially if it's not a force function, but is more about changing, is more reliant on human behavior and involves people changing their routines. So we've used that to help reduce our rates.
Thank you so much. There's another question in the chat regarding CBP monitoring and its utility in indicating fluid status. But the attendee had brought up a question about the leg raise or leg rise test as a measure or surrogate of fluid responsiveness. Just wondering to hear your thoughts about that.
So in reviewing the literature and the ESPNIC guidelines, apparently the leg raise test, and also like when I was in fellowship, we learned to like push on the liver, does not have great evidence of correlating with fluid responsiveness. But fluid responsiveness in the ICU is really difficult. Even echo, right? Like we're hearing now, compressibility of the IVC is not a strong indicator of fluid responsiveness. You know, sometimes cardiology will tell you the LV looks empty. But I find fluid responsiveness to be one of the most difficult to assess basics in PICU. And I think the most important thing that I teach our trainees is fluid is a medication, and you need to deliver it in hemodynamically unstable patients at the bedside and watch the response. So I actually draw it up into syringes, even on a big patient, and push it and look at the response. Because otherwise, in a shocky patient, you're doing a bunch of other things at the same time, and you don't get a sense of if they truly responded to fluid.
Thank you so much. I know that we're at 1 o'clock now, so I just want to again say thank you so much for that fantastic presentation and hand the stage back over to Dr. Al-Husseini.
Thanks so much, everybody. Have a good day.
Thank you for the fantastic presentation. I'm going to give the microphone to Dr. Asma. She is going to handle the discussion part of the low resource settings monitoring with Dr. Nombini. Dr. Asma, please unmute yourself.
Hi, everyone. I'm just waiting for Dr. Nombini. So we, due to technical difficulties, lost some of Dr. Nombini's lecture, but we're also running a bit ahead of time. So we're just waiting to see if Dr. Nombini can connect again. I think she's also having some bandwidth issues on her end. Dr. Zosie, are you with us?
Yes, I am, Asma. Do you want me to share my slides, or are you going to do it from the other side?
Do you want to go ahead and share? Can you do it from your side, or should, in the interest of time, should we do a discussion?
Okay, whatever the panel wants. Maybe let me just show my face so that they know who I look like. Okay, hi everybody. I hope you can see me. I'm Dr. Zosie. I'm from the Eastern Cape part of South Africa, and I'm coming from a very low resource center. But I'll just then answer the questions that Asma wants me to respond to. Thank you. Then I'm going to switch off my video just for connections sake. If that's okay with you.
That's fine. Thank you so much, Dr. Zosie. And thank you so much for all the effort that you put in to do the presentation. And I think the technology has worked against us this evening, but just your efforts have been really well appreciated. So if you want to give us a bit of a summary and tell us about how you use monitoring in your ICU setting, and maybe give us a background of your ICU setting for some of the audience, and go through some of the monitoring that you use in your setting, and what advice you normally give to your juniors in terms of carefully monitoring the critically ill patients in your unit.
Okay, thank you, Asma. So, like I said, our unit is very small. It admits patients that are more than, it's actually neonates that are coming from home, and also anyone else then from the ages of 1 month to 12 years. But it's also those children, those neonates that are coming back from home. So the way we monitor our patients in our unit is that it's actually important from the emergency department already, where we have to go on clinical evaluation of our patients, especially children that we see the most is those that have got shock and have got respiratory issues. So what is important is that we'll initially go clinical, look at all the clinical signs like look out for tachycardia, bradycardia, monitor the blood pressures. And unfortunately, the blood pressure that we're using there is oscillometric. And Dr. Brianna actually explained that beautifully. That was part of my presentation as to how that works. We don't have the auscultatory type of monitoring, but then in the ICU, we do sometimes, it sometimes works and it sometimes doesn't work. The issue that we have with that type of monitoring is the fact that we've got issues of blood pressure cuffs. And I think it is important, that was part of my presentation, that it is important to get the sizes correctly, because if you do not know what the correct size is, which in children is supposed to measure, first of all, the point of measurement is you measure from the shoulder to the elbow, and then you midway of that you get the diameter of your upper arm, and then from there you measure the bladder, not actually the actual cuff, but the bladder of the cuff. It should be about 40% the width, and then the length of that should be about 80%, and make sure that it covers the whole arm. And like Brianna had said, it is very unreliable because with oscillometry, also with auscultatory, because with auscultatory sometimes it does not pick up the diastolic pressure, and then with oscillometry, it's also not reliable because it's actually worked out from the mean airway pressure. But I think that the sepsis guidelines have actually helped us a lot, because now we do not have, the surviving sepsis guidelines have helped us a lot because we do not have now to use the mean airway pressure, so we can actually use systolic pressure. So that can actually help a lot in centers where we do not have, we've got limited resources. And then that's part of the topic that I was talking about, monitoring of blood pressures.
I'm just going to interrupt you there. So that I've just shared on the screen. I'm not sure if people can see it, but it's a picture of one of the slides from Dr. Zozi's talk. And like Dr. Zozi was saying, a lot of times the lower resource settings have been neglected through, if you look at most of the literature, but probably in the last 5 to 10 years, there's a whole lot more focus and acknowledgement of the fact that low resource settings have needs, and also to get data and to study patients in low resource settings, because a lot of the burden of sepsis actually predominates in low resource settings. So one of the things that came out of the surviving sepsis guidelines of 2020 is this alternate definition of hypotension in healthcare systems without intensive care. And so you can see, instead of using mean arterial pressures, they actually give systolic blood pressure parameters. And even in the absence of having blood pressure monitoring, you can actually use the WHO criteria of cold extremities, prolonged capillary refill time, and pulse aberrations. So that was just one of the slides that Dr. Pinky had from her talk, Dr. Zozi. Yeah. Sorry.
Yes. And then, so the other important thing that for oxygenation, we can use SETs, and that has been around for a long time. But then what is actually important with the pulse oximetry is that it actually doesn't pick up sometimes when it's cold. So people need to take to bear in mind about those limitations of using a SET monitor, because if it's cold, or the patient is moving, or the patient is vasoconstricted or is hypotensive and he's on vasopressors, or the patient has got dark skin, or has got the nail polish. So those are some of the limitations, but also it is not reliable when in conditions whereby there's some hemoglobins that can be picked up by the SET monitor. Like, for instance, we see a lot of burns in our unit, and then those patients that have been exposed to fire burn, they can have carboxyhemoglobin, and then that will actually be picked up by the pulse oximetry and be read as if it is oxygenated hemoglobin, because the wavelength at which that light is observed is absorbed. It's very close to what the the oxygenated hemoglobin is, which is around about 660 nanometers. So it would read as if it's a normal set while the patient is actually hypoxic. So that we need to pay attention to that. And also if then, also some other hemoglobinopathies like methyl hemoglobin. So that one, it will actually show that the patient is actually cyanosed. The cells will read on the lower side. So if then you are in doubt, you then need to do a proper oximetry where you send the blood to the lab. So that was one thing that we need to talk about. Pulse oximetry now comes back with perfusion index. And a lot of studies are now done to try and help monitor patients using both perfusion index, and also you can use the pulse oximetry. So before I move away from the pulse oximetry, I wanted to also talk about how PRDS guidelines now, the policy group has actually considered low resource settings, whereby where people do not have blood gas machines. Now we can use the SF ratios, or we can use the OC to actually try and make diagnosis of our patients that have got PRDS, and then you can actually be able to stratify these patients according to severity using those parameters. I don't think it's just meant for, yes.
Thank you so much. I think I know you have lots to say, and I'm sorry that we didn't get to go through your whole presentation, because I think there were some very important learning and take-home messages from there. I think just in the interest of time, we'll wrap up there. Is there one last take-home message that you'd like to give us, and then we can go on to Dr. Bassam?
I think that we should use the parameters that we have, and we do not have to have the fancy things, because now there are some other tools that could help us to try and monitor our patients. And I think also once you've then done your monitoring, you just need to have all that information documented somewhere. Like we've got charts in our unit whereby we can actually document all the information that we have, all the parameters, and you can actually look at it, and it gives you a lot of information, so that you are able to see where the problem started, and when you teach your unit teams, so that they are able to act on those. So I think we can still do the best we can at limited resource centers using the parameters that we have and using the resources that we have. And I think if we just try the best and do the best with the little bit that we have, I think we can actually take good care of our patients, going clinical, and also the minimal resources that we have. I think I'm going to leave it there.
Very nice. Thank you so much.
Your work and the great work that you do. Thank you very much, Dr. Zosi, for joining us and for sharing your insights with us today.
Thank you also, Dr. Asma, for moderating the session. And the floor is yours, Dr. Bassam, for a couple-minute presentation about our fellowship before we close.
Yeah, thank you, everyone. That was a great webinar. So yeah, I'll just start from the beginning, because I started talking and then I think I got cut off somewhere. So anyway, my name is Dr. Bassam. I am a pediatric intensive care consultant at King Faisal Specialist Hospital in Riyadh. So I'll talk about the fellowship. We're starting tomorrow, so I hope all of you guys join us. It's going to be great. So I'll talk about the framework overall. It's going to have 3 modules, and then each one of these modules is going to be 16 weeks. And every week we're going to have a lecture, journal club, multiple choice questions, a lot of questions, and clinical case scenarios. So it's going to be like a packed week, and we'll go on from there. After you complete the program, what we expect from you is to graduate at a trainer or mentor level, and to be able to join the tutoring panel in the incoming programs. And we expect you to gain expert level knowledge in pediatric critical care. And you'll also have the American Association of Continuing Medical Education graduation certificate. Just looking at the panel today, like you can tell that our board is pretty diverse. So we have attendings from the US, from Canada, from the UK, South Africa, Saudi Arabia, and Egypt. And you know, like with that broad diversity in the board, it's going to manifest in the lectures themselves. When you look at the course materials, it's going to be interactive. It's going to be question and answer, evaluation and assessment. And there's going to be a focus on critical thinking. It won't just be like memorization of random facts. It's like we want you guys to be better clinicians. Like that's what this fellowship is for. Like diving into like what a week is going to look like. So all scientific material will be released at the beginning of the week, 8 a.m. GMT on the online portal. You'll be able to navigate the material and complete the tasks throughout the week. And then by the end of the week, you are expected to submit the assignments every week. So every week, by the end of the week, everything should be submitted, and then you'll receive an individualized evaluation based on your performance. So an example of what might be in the fellowship. I wanted this to be more interactive, but unfortunately we weren't able to set up the poll. So I just want you guys to be like interactive in your minds. But so this is an example of a question. You have a 5-year-old boy. He's admitted to the PICU with respiratory failure secondary to pneumonia. He's intubated, and you are concerned about ARDS. Which of the following monitoring parameters are essential for making a diagnosis of ARDS? So here I tried to bring in ARDS and and the monitoring, and lucky for me, like if you were paying attention, Dr. Nombini has mentioned it. So like the 4 options are end-tidal CO2, blood pressure, peak airway pressure, or oxygen saturation. So for the sake of time, like I won't dwell too much on this, but the correct answer here is oxygen saturation, like Dr. Nambini mentioned, because when you look at ARDS, actually we'll talk about it in a couple of slides, but oxygen saturation is important to make a diagnosis of ARDS. CO2, ARDS is an oxygenation problem, and so CO2 has nothing to do with it. Blood pressure, nothing to do with ARDS. And then peak airway pressure, if you're thinking about mean airway pressure, then you would be correct. But solely looking at peak airway pressure, that's not what we're talking about. It's not essential to make a diagnosis of ARDS. Then every week, in addition to, so this would be a question based on a lecture. You will have the journal club. This is an example of an important lecture. And it was mentioned in Dr. Nambini's talk. This is the latest guidelines for ARDS, and this is the table that was in the talk. And as you can see, in regards to ARDS, we're looking at oxygenation, and oxygen saturation is important. So you'll either need an arterial line and to measure the oxygen from there, or oxygen saturation to make a diagnosis of ARDS. Building on that, at the end of the week, as we mentioned, you're going to have case scenarios. So this is the same case with a little more information, okay? So the same 5-year-old boy is admitted to the PICU, secondary to pneumonia. According to the guidelines, he does have severe ARDS. He's intubated on conventional mechanical ventilation, SIMV pressure control modes, and the settings are as follows. The rate is at 30, PIP is 20, PEEP is at 5, and FiO2 is at 100%. He's achieving a tidal volume of 5 per kilo. His blood gas shows a pH of 7.25 with respiratory acidosis, and his oxygen saturation is 70%. Okay, based on all of that, which of the following is the best next course of action? Are you going to high frequency? Are you going to increase the rate on the ventilator to 40? Are you going to increase the PEEP up to 10? Or are you going to switch the ventilation mode to SIMV volume control instead of pressure control? So again, this is based on ARDS, and an important topic that you focus on in ARDS is lung protective strategies. And the correct answer here is going to be to increase the PEEP. That would be the best thing you can do. Increase the PEEP to be able to decrease the FiO2. That would be the correct answer. So you wouldn't go to high frequency. These vent settings are way too low. You won't increase the rate because as part of a lung protective strategy, permissive hypercapnia is fine and the pH is okay. And you're not switching from pressure control to volume control. That wouldn't really help the patient. You just need to increase the pH. So hopefully you're going to learn that and a lot more in the fellowship. When you look at the modules, I'll go through this quickly. So when you look at the modules, as we said, there are 3 modules. The first one is going to focus on core knowledge and basic principles. The second one on specialized topics. And the third one on advanced critical care management. So looking at the first one, we're going to have shock. We'll talk about ID. And we'll talk about renal critical care. Going on to the second topic, or the second module, this is a little more specialized. We'll talk about respiratory critical care, cardiovascular critical care, nutrition in the ICU, and POCUS in the acute setting. And then for the last module, it's going to be about advanced critical care management. We'll talk about neurocritical care and TBI. We'll talk about endocrine and metabolic disorders, and oncologic and gastrointestinal disorders. Like, as you can see, it's a lot of information and you're going to learn a lot, God willing. So looking at important dates, the start date, as you can see, is tomorrow. So come with us on this journey. And then hopefully by July 21st, you'll be done and you'll have your certificates, and like more important than that, like you'll have a lot more knowledge about ICU, and that'll help you with your patients. So this is the fellowship landing page. Unfortunately, you can't click on the link, but you can follow it. And there's the promo code, and good luck, everyone. Like, hopefully you'll join us on this journey. Yeah.
Thank you so much, Dr. Bassam, for the great demonstration. Just housekeeping stuff. First, I really thank all of our panelists, our moderators, speakers, and our attendees as well. You have been very patient with us for over a half and 20 minutes, 1 hour and 20 minutes. Thank you so much for that. The other thing is the recorded video of this webinar should be available tomorrow and will be shared with you. Third is all attendees will get certificate by next week, certificate of attendance. Next, I will make myself available tomorrow at the same time as today for our fellows' questions and inquiries. So I'm going to send in our BCC Fellowship WhatsApp group a link to meet. So if you have any question, don't panic, don't worry. There is no problem. It's a problem-free philosophy. So, just try to be patient, and tomorrow we'll be able to answer all your questions. And with that, I'm going to close the session, and we'll see you all next month in our next webinar, which will be focusing on vasopressors and inotropes in our critically ill children. Thank you.